one of the benefits, obviously sedation makes them hold still, which is super helpful. But the other benefit is that it lets them relax their bellies. And when you really need to push down deep into the abdomen to see something like the adrenal glands or the medial iliac lymph nodes or the full depths of the liver or biliary tree, right? It's hard if you're kind of pushing against a taut surface.
Hey, VetFolio Voice friends, I'm so glad you joined us for this episode. I learned so much from this conversation, and I'm thrilled to share it with you. In this episode, Dr. Erin Porter joined me in the studio, which is always so much fun, to talk about all things imaging. Together, we talked about different imaging modalities from radiographs to ultrasound to CT to MRI, and how to choose the best modality for what we're trying to accomplish for our patient. Our talk included a really helpful discussion on ultrasound, which is, of course, becoming more and more common in practice. And we talked about some areas where ultrasound can really shine, but perhaps more importantly, some of the misconceptions about what ultrasound can accurately detect. We also spent some time on CT, which is also becoming more and more readily available, and how perhaps the old explanation of CT for bone, MRI for soft tissue, maybe doesn't give CT enough credit for all that it can be used for. And our discussion of CT also led to a fascinating discussion on ultrasound versus CT-guided sampling and the pros and cons of each. I certainly learned some things I didn't know before about obtaining samples, especially when it comes to some of the limitations of ultrasound-guided sampling. And of course, we did not leave out MRI. We talked about the situations in which MRI would really be indicated over CT and how to help guide clients when making a recommendation about imaging. Dr. Porter was a fantastic guest, brilliant, and an amazing teacher. Let me introduce her so we can all learn together. Dr. Porter is a 2007 graduate of the University of Florida College of Veterinary Medicine. Upon graduation, she worked as an equine ambulatory practitioner in the Orlando area for 2 years before returning to the University of Florida for an equine lameness and imaging internship. Dr. Porter completed a residency in diagnostic imaging at the University of Florida and became a diplomate of the American College of Veterinary Radiology in 2013. As a faculty radiologist at UF, she was designated Service Chief of Diagnostic Imaging from 2017 to 2021. In 2021, she became board certified as an equine diagnostic imaging specialist with the American College of Veterinary Radiology. Her imaging interests include equine musculoskeletal imaging and small animal ultrasound. And in her spare time, she enjoys jogging, yoga, and spending time with her 2 children.
Nutrition is the cornerstone of our patients' health and happiness. The veterinary healthcare team should be the ultimate source for top-notch pet nutrition info. When clients see how the right diet helps their pets stay healthy and happy, they visit us more often. Remember, good nutrition is essential. It's smart business and great medicine. Enroll in the NAVC Pet Nutrition Coach certification today on vetfolio.com.
Well, for this episode, I'm really excited. This is another in-person episode, which are my favorite when we get to sit down face-to-face and use our Gainesville studio here. I'm joined by Dr. Erin Porter, and we have been down all of the rabbit holes before we turned the microphones on, but now we're going to stay focused and talk about radiology. So thank you so much for joining me.
Thank you for having me. I'm excited to be here.
Yes, I'm excited to have you because with so many things in veterinary medicine, the questions never end. But for me, radiology is definitely that subject for me where I'm like, but what about this? But what about this? I never feel like I've really got it. So I'm excited to pick your brain.
Yeah, I think a lot of people feel that way because, there's definitely an art to it. I mean, you can read in a book and learn everything you can, but still there's an art that just, makes it more challenging for sure.
Yeah, it's like a lot of things. There's just kind of a feel to it. And, I don't think I was born with that natural touch for radiology.
Me neither, actually.
I
get you.
You neither. Do you just attribute it to years of practice?
Years of practice, yeah. Reading lots and lots of images, for sure.
I think that's really encouraging to think about it that way and say, that you feel like you weren't born with that natural ability to read x-rays and position these images and really get the diagnostic result you need. So, I mean, that means there's like hope for us out there.
There's hope, for sure. We can be trained.
Good to know. All right, I'm going to remember that the next time I'm struggling to take an x-ray.
Definitely.
Well, certainly in veterinary medicine, we've had the option for lots of different imaging modalities for a lot of years now, but it seems like they're becoming more and more readily accessible when we're talking about things like certainly x-rays, but ultrasound, CT, MRI. So I guess maybe this is an obvious question, but why is it important to kind of understand all the different modalities that we have available? And, what is something you wish we all knew about the difference between the modalities and how to select them?
Right. Yeah. And like you said, there's a lot of different options. And for most of us in small animal practice, right, we're going to use x-ray as our starting point. So most of us have pretty accessible x-ray equipment in our offices and, the ability to interpret it with different levels of comfort. So that's usually a great starting point. And just to kind of go down sort of the list of modalities before we kind of jump into the benefits of when to use each one. Ultrasound is probably second most accessible, right? Many small animal clinics these days have pretty high quality ultrasound machines, and a lot of people are just using them for fast scans, but there's obviously so much more that can be applied there. And then CT is becoming more and more readily available, even locally here in our community. We're seeing it. Used to be kind of just the university, and now there's several private practices around town that have them. And then probably the least available of those is MRI, and we can talk about kind of the pros and cons. But all of these modalities are complementary to each other in some way, right? So it's not that, you hear MRI is best for soft tissue and CT is the best for bone, but CT is actually great for soft tissue in some cases. And so learning sort of those like fine details of when one modality helps us sort of better understand another modality is so important and so applicable in practice.
That makes sense. And I'm thinking, talking to owners about doing chest x-rays versus an echocardiogram, and the way I've kind of explained it is exactly what you said. These complement each other, and one, we're kind of looking into dimensions, and these are the structures we can see. And then when we add this more three-dimensional ultrasound picture to this, and we can see the blood flow and some of these different things, we get a lot more information. And so it makes sense that all the different modalities kind of build on each other.
Yeah, absolutely. Yeah, I mean, just going with your example there. So with cardiac disease, you may pick up a murmur, and oftentimes the first step is going to be to take chest radiographs, right? Because that's the most available. And chest radiographs are going to help you identify, to some degree, abnormalities in the heart. But what we know from I can tell you from my experience, but also from the literature, is that we're actually not very good at diagnosing cardiac chamber enlargement with chest x-rays, right? So we're decent when you're looking at a left atrial enlargement. We're not very good at right-sided cardiomegaly, and that's in dogs and cats. We're not very good at diagnosing really any of it, and definitely not specific enlargement of certain chambers. But it does help us to diagnose heart failure. So different from echo, with x-rays, we can look at the lung parenchyma. We can look for, an increased soft tissue opacity that would tell me that there's pulmonary edema, for example, with left-sided heart failure. We can look at the vessels and say, okay, there's big veins, pulmonary veins, right, which tells me that there's potential for left-sided heart failure. Or look for pleural fluid, which would go along with right-sided heart failure, or evidence of decreased serosal detail in the abdomen, which we can't do with echo. But with echo, we can get a much better look at those chambers and really see, if they're dilated, are they eccentrically dilated, or are they, how are they affected, and what do the valves look like, and do we have regurgitation, like much more specific information about the valves. So really they need to be used together to figure out kind of the whole disease process. So that's a great example. And I think another case where probably there's a lot of confusion is with x-ray versus ultrasound when it comes to your intestinal obstruction cases.
Oh gosh, yeah. I've seen that go both ways.
Yeah, and it's a common one, and it's challenging for sure. And so when we're looking for an obstruction in a dog, right, a foreign body obstruction or whatever the cause may be, an intussusception, maybe sometimes it's cancer even, that can be causing obstruction of bowel. The thing that really gives us an objective cutoff to answer the question, is it obstructive or is it not, is surprisingly x-rays. I think most people think, oh, you really need an ultrasound to know. And I get that all the time. Oh, we're referring this case for an ultrasound because we need to know if it's obstructed. And actually, like if you use the right measurements and the right tests, we can determine obstruction with x-ray alone. And so what's the benefit to ultrasound there, right? And so the reason to use ultrasound in cases of obstruction are a couple things. Like one of the big ones for me is linear foreign bodies. So I find linear foreign bodies to be really subtle. They tend to not have distension of small bowel like you see with like, different from like a regular old plug. You got a Kong in your small intestine, right?
Ball.
Right. With those, you tend to see two populations of intestines. So you'll see one group of small intestines that is abnormally distended. And by that, I mean greater than 1.6 times the mid-body height of L5 on the lateral projection. So very objective criteria to say, okay, this is obstructed. This is my cutoff, right? With linear foreign bodies, you don't get that distension. You just get bunching and you're looking for subtle fragmented gas patterns. And for me, it's much, much more subjective and more challenging. But on ultrasound, that plication becomes really apparent and really obvious. So to me, that's a great place to use ultrasound for obstruction. The other time is if you have an obstructed case and you're pretty confident that you see that radiographically, would be an older animal where you're concerned, maybe the clinical signs have been sort of more insidious and it's an older animal and you are much more concerned about it being neoplasia causing the obstruction versus a foreign body, right? And maybe those owners aren't going to want to go to surgery in that case, which is fair enough. So ultrasound can be a great test for that to say, okay, we have an obstruction, like you said, but it's due to a mass obstructing versus a foreign body. So the downside to ultrasound with obstruction is we can't necessarily characterize the content. So I had foreign material will cause shadowing. And so we can't see anything more than just the margin of it. So I feel like I get that question a lot. Well, can't you ultrasound and tell me if it's towel or if it's a hairball or if it's what it is? And I'm like, all I can tell is the margin. So for that, I will often, even after I'm done with my ultrasound, send the patient back for x-rays to try to get a better idea of that kind of thing. So definitely I use them back and forth, complementary all the time. And I think it's probably one of the more misunderstood concepts when it comes to diagnostic imaging.
I know I have definitely been guilty of that. I've since learned that, I can get a lot of this information on x-ray. And with ultrasound, unless like you're talking about with a linear foreign body, it really needs to be used as a complementary modality, like not jumping straight to ultrasound for a foreign body. But, when it wasn't as readily used, absolutely, that was where my head was at. Was like, okay, we're going to send you to ultrasound. We're going to find out what it is.
Yeah, absolutely.
But if
You're
we're
not
ultrasounding, that's good to know.
Yeah.
When we're ultrasounding for that foreign body, like that would be when you're like sweeping across the abdomen, right? Like, I'm sure if it's duodenal, there you can trace some of it, but if we're like just in a bunch of jejunum, like you kind of have to come across that foreign body to get that diagnosis.
Right. So it's really important to be systematic. So when I do an abdominal ultrasound, as a radiologist, I do a little bit more of a whole abdomen approach than even is maybe always necessary, but I'm going to scan every organ. And then when it comes to the small intestines, I'm going to sweep like from one side to the other. So I'm going to see the left body wall, the right body wall, the pelvic brim, and the diaphragm. And I'm going to sort of serpentine up and down the abdomen using my probe in both transverse and long axis and make sure I don't miss a square inch of that abdomen. Now, I don't normally I do follow the stomach down the duodenum to the caudal duodenal flexure, and then I follow the colon all the way up from the, rectum as far as back as I can get to the ileocecal junction, and then I do that whole sort of sweep, right? Like you said, the sweeps from the front to the back, from side to side, and I'm pretty sure I'm not going to miss anything if I do it that way. Yeah. So it is. You have to come across it, but if you're systematic, you will.
Yes. So be systematic and do a good, because I'm picturing myself doing this. I'm like, oh, I know. I'm sure I've skipped some real estate on that abdomen before.
Oh, it's easy to do for sure. And there's limitations, if you have a really big dog, like every now and then I have a dog where I'm like, so the literature, the cutoff is 25 kilograms, I believe. So if it's 25 kgs or more, then the literature says you're more likely to miss things, and CT is probably a better option for those cases.
Okay.
Yeah.
That's a good good number to just kind of keep handy to say
Yeah.
how successful are we going to be.
Right. So if you have a large Shepherd or a Great Dane or, any kind of giant breed dog and you refer it for an ultrasound or you're working on, struggle busing through an ultrasound like we all have on those dogs, just warn the owner. That's what I do. Like I am missing things is what I say. Right. And just know there are better tests out there.
Yeah, I think I referred a 150-pound Mastiff to you at one point to check his liver.
Yeah, I cringe when I get those a little bit. And for some things, it's fine. Urinary bladder and kidneys, really, there's not a dog too big for that. But when you're talking about the liver, it gets more challenging, and the body conformation really makes a difference. But that's probably a good segue into CT then.
Absolutely. And before we go to CT, because I agree with you, I want to talk more about CT. Can you talk about the role of sedation when it comes to ultrasound? Because I've taken your course at Institute and all of the dogs were sedated and we could see like these beautiful images. And not all of my dogs are sedated in practice, and I've noticed a huge difference. And, I think that was something that all of the instructors spoke to us about a lot was sedation for ultrasound. So are you at sedate them all every time kind of ultrasound modality, or is it kind of case dependent?
Such a great question. And I think it's something that intimidates a lot of people, right? They're like, I can't get into doing that much ultrasound because I don't have time, or I can't sedate all my patients because they're not stable enough, or, whatever the challenge may be. I am absolutely not. I would say that most of my patients get sedated because by the time they come to me, they've had sort of several attempts at that point, or they're looking for something more subtle or that kind of thing. So in my practice, they generally get sedated, but it's certainly fair to try without. One of the benefits, obviously sedation makes them hold still, which is super helpful, but the other benefit is that it lets them relax their bellies. And when you really need to push down deep into the abdomen to see something like the adrenal glands or the medial iliac lymph nodes or the full depths of the liver or biliary tree, right? It's hard if you're kind of pushing against a taut surface. And so even if the dog's holding still and they're just not, if they're just too tense, sometimes just a little bit of butorphanol or something like that can just take the edge off enough to let you kind of get a little bit more pressure on the abdomen. But absolutely, I have plenty of patients that we can scan fully awake and get a good diagnostic scan. And even more so if you're looking, if you're not doing a full abdominal scan, if you're doing, say, I'm checking out the kidneys and the urinary bladder, more often than not, I can do that awake. Cats are surprisingly similar in that. Like they kind of get that fear paralysis thing happening.
They do. Yes.
Right? So you think they would be worse, but usually they'll just kind of freeze and stare at you. So that actually, they're even easier without sedation. But the bottom line is I think the owner needs to be told that in order to get a full exam, it's possible that they may have to be sedated.
I like the suggestion of even just a little bit of butorphanol can help in some of our more well-behaved patients that we just need a little something, because a lot of animals, you can give them a reasonable dose of butorphanol and they can probably walk out of the hospital within an hour or two and be okay to go home and take a nap.
Right, yeah. Though we warn them they're going to be sleepy for the rest of the day, but yeah, they usually recover and go home okay.
Sure. Okay, well, that's good to know, to kind of, play it situation by situation, but if you can get them to relax a little bit. I do think that was one thing I learned about ultrasound was really, there are times where you really have to apply that pressure to see down deep into that abdomen.
Right. And even if they're cooperating and they're tense, if they're doing crunches the whole time, you're not going to get what you need, unfortunately.
Makes sense. It makes sense. Well, let's talk about CT. When I think of CT, my sister is a human internist, and she calls it the cone of truth. And so I have this image of CT, and I don't have a lot of experience with CT because it's not readily accessible in vet med in a lot of cases, although we are, like you said, seeing it more. I have this image of like, in my head, an image, get it? No pun intended. That I put this animal into the CT and like I have all the answers of everything that's ever happened to them. But I'm guessing maybe there's some more limitations than that.
No, I mean, I think it's good because I feel like actually when I was a student, which is a very long time ago at this point, but when I was a student, I learned, or at least what stuck in my brain was CT is good for bone and MRI is good for soft tissue. I don't know if you...
I have also heard that.
Have you heard that? Yeah. So that was kind of my thought was if it's anything bone, we can CT like fractures and that kind of thing. But I would say far and away, when we're reading a lot of CTs, like at the university. The bulk of them are actually for soft tissue things, right? So you can use IV contrast to really highlight anything that has vascular perfusion, so all of your organs, all of your lymph nodes, and then abnormal things like tumors or abscesses, right? And you can see something that has kind of a necrotic or juicy center, right? Cavitated lesions will have contrast enhancement on the periphery, but it's not going to fill the juicy center, right? So we can really appreciate sort of the subtle differences in different tissues. CT is based on Hounsfield units, meaning the attenuation of tissue is based on, right, how dense something is relative to water. So water has a Hounsfield unit of 0. Fat has a Hounsfield unit that's in the negatives. Metal is in the thousands. Bone is in the hundreds. Soft tissues may be somewhere between like 25 and 50 and up to 100, right? So variable degrees of Hounsfield units that we can actually measure. So I can use CT to see how densely soft tissue attenuating something is, how much contrast enhancement is in that mass, and that gives me even more detail about things. So it's actually a beautiful tool for things like soft tissue neoplasia, certainly for looking for METs in the lungs or evaluating masses in the lungs that we might have a hard time on radiographs. One of the big things is sometimes it's hard to tell if it's a mass in the mediastinum versus a mass in the lung. And so CT will answer that question. Some of those very subtle pulmonary metastasis cases, CT is great for that, but also for surgical planning. So you have a big liver mass, and the surgeon is going to be much more comfortable knowing exactly which liver lobe is affected, and are there smaller METs elsewhere in the liver before they go in for a major surgery. And so it's excellent for that kind of thing too, which for me, it took residency to learn that. I think now maybe people learn more of it in vet school, but yeah.
I did not learn it in vet school, at least. I mean, we probably did talk about it, but focused much more on radiographs and ultrasound. Sure.
And it's changed so much over the years, right? So like what we use CT for 20 years ago is very different than what we use it for now. So I feel like it's truly is. I'll quote your sister on that one, the cone of truth.
The cone of truth.
Yeah.
Well, and I also remember doing anesthesia before I went to vet school that a lot of these patients, we had them fully anesthetized to go for CT. And I think I see it more so done under like outpatient sedation now.
Yeah, so that's a good point. You do need anesthesia in some cases. So for example, if you're imaging the lungs, and you don't want that respiratory motion. The scans are so quick, and in the newer scanners, you can have a whole body of a dog in seconds. Really, truly under probably 6 seconds.
Yeah, I think we're in that like almost 20 year ago range when I was anesthetizing things for CTs.
Right. No, I mean, so they do have to be anesthetized for things like looking at the lungs, right? So I do still require anesthesia for pulmonary or thoracic CT. Most of my abdominal CTs I'm doing now are sedated, and it's a quick sedative, And then the other thing that we can use CT for that may be sort of forgotten is sampling. So everybody thinks about, you need a FNA of a mass. Like you're going to then have to go to ultrasound, right? And so CT guided sampling is absolutely effective, and sometimes more effective. So if you're trying to sample, for example, like a mass in the lung, I can't see that with ultrasound unless the mass is touching the pleural surface. So I've had a couple cases that people have referred dogs to me to sample a lung mass, and radiographically it's hard to tell, but if the lung mass isn't touching the edge of the lung, I'm not going to be able to see it with ultrasound, and so those require CT. Yeah, so very complimentary in that regard.
I'm like putting all these notes in my pocket, like don't refer for this, this is a different modality, and that's why we're doing this talk is to understand these different modalities.
And that's part of what I see as my job. Like any radiologist that you work with is usually happy to talk over that. So, I love when people call and say, hey, I have this case, I want to refer, what's the best test? I'm like, yeah, that's what I like to talk about, so that really, I love those conversations. And I think a lot of people probably do, because it helps us make the best decision for the patient,
Absolutely. I think, I don't know, maybe this is just me. I think I picture radiologists as like you're like these magical people who I'm like, I go forth and get the sample from this thing, and you can like magically make the whatever we need appear on the screen and get samples of it. So I think it's good to know the limitations of like, okay, well, I realize you referred this to me in order to get this sample, but like that's not actually possible. And we can save a lot of confusion on everybody's parts by having that communication and
Absolutely.
saying, all right, how are we going to get this sample?
Yeah, I wish I was magic.
Yeah. I still think you are. Like, for how much I struggle with radiology, just internally, and still feeling like I need more practice all these years out, I still do think you're magical.
Aw, thanks. It does. It does take practice, no doubt.
So let's talk about CT-guided sampling for a minute, because this is a new concept to me. I absolutely pictured, okay, take them out of the CT. But again, like, we're maybe in that 20-year ago range of when I was, watching a number of CTs. And so it sounds like you're saying the scanners that we have now are different. They're much faster, and that allows us to get, different and better scans than we could originally. And I'm imagining that also plays into being able to sample with these patients.
Yeah, I mean, I think that's the cool part about diagnostic imaging, right? Is we're in this world where technology is just like rapidly advancing. So probably this conversation we're having now will absolutely not apply in 20 more years, and the same thing applies for us 20 years ago. The scanners are super fast. For sampling, we just use the CT to guide our needle placement. So we put the needle into the pulmonary nodule or whatever it may be, and then we get a CT acquisition, which is, in that case, could be just like 1 second peek, make sure our needle's in the right place, and then you get your FNA. So it's sort of more of a CT guided versus like watching yourself acquire the sample, but it allows us to really get into smaller structures that we can't see with ultrasound, structures that we can't reach as much with ultrasound, we can use CT for. So it's got some benefits over ultrasound. And again, complementary. Ultrasound sometimes is quicker and easier and more readily available. So if I can do it with ultrasound and I have one, then that's going to be the way to go for sure.
So I'm picturing you're going to look at the CT image and measure where it is that you're going for this lesion and say, okay, if everything is what it appears to be, then if I put my needle here, I should be in the right place.
Yeah, absolutely.
Wow.
Yep.
And then you're just putting your needle into the you are magical.
Yeah. That is fun. It's fun and it's cool and it's really rewarding when you get, the sample you're hoping for. But
Absolutely. I want to jump back to ultrasound for a minute, because we've talked a little bit about echocardiogram, we've talked a little bit about abdominal and fast scanning, but there's a lot more that we can be using our ultrasounds for in practice. We've talked a little bit about musculoskeletal scanning, cervical, and also I'd love it if you would talk to us a little bit about blocks for anesthesia and surgery. I know those are becoming more and more widely used.
yeah, so a lot of anesthesia teams are able to use ultrasound-guided, local anesthesia techniques to numb that area, right, to help reduce the amount of inhalant that they need during surgery. This oftentimes requires a little bit of a more advanced ultrasound, so you're going to usually, for many of these blocks, want to be using your linear transducer. So if you have, when we talk about ultrasound, and maybe I should back up a step, right? We have different frequency ranges depending on the probe you're using. So your little microconvex probe, probably the one that most people have with their machine, gives you about 5 to 8 centimeters of depth. And that's going to be great for like your mid-sized dog abdomen, right? When you're talking about looking for very small nerves and the superficial structures, like, for example, if your tap block, right, in the abdomen before a spay, a lot of people are starting to do, you're going to need a higher frequency probe, because that probe allows you to get really beautiful high resolution images in only a couple centimeters of depth. I think that one of the big things that sort of the biggest piece of advice I give techs when I'm helping work on these kind of blocks is just kind of learning the machine, learning how to optimize your image. Once you learn the landmarks and you know how to really maximize the quality of your image, those blocks are going to fall into place, right? They're really not hard. It's just a matter of if you are using the right probe. Are you decreasing the depth so that you're only looking at those few centimeters where that nerve lives? A lot of times people, they're in a really well-lit room, right? An exam room, pre-op, and they're using the probe they always use, and so they're at like 5 centimeters. The well-lit room makes you turn the gain up a little bit because it's harder to see. You're sort of setting yourself up for failure in those cases. So my suggestion, if you're going to be doing blocks, is to get pretty comfortable with the utility of your machine. And so that's, it sounds scary, but it's only a few buttons really: your depth, your focus, your gain, and then choosing the correct probe for the depth you need. The higher frequency probe for less depth will give you a much better image. And that's stuff that a little bit of CE, usually that's something they focus on even the more basic ultrasound CE courses like we have at Institute or at VMX. But those are going to be the difference between success and failure when it comes to those blogs. I'm not sure if I answered the question there. But
I think you did. It sounds like it really comes down to getting that high quality image. Like the technique for placing the block is something that we can all learn, but not unless you can really get the image that you need and know you're placing it in the right place.
Exactly. Right. Once you learn the landmarks you can read in a book, for sure, getting the image so that you can identify the landmarks is probably the harder part. And it doesn't necessarily mean you need a $60,000 machine. I mean, it's always helpful, but you can do this with probably even a butterfly or a laptop-based machine, as long as you're really optimizing your images and, using it appropriately, maximizing the use of it.
Okay, now I want to try it because that's what I have. Because being mobile, it's easy to carry it around without having to have an extra case with me. Now I'm curious.
Yeah, absolutely. If you have the option of a linear, if you're going to be doing a lot of blocks, tap blocks, and also, like I should say, for musculoskeletal imaging or ocular imaging, anything, a lot of CATs, even, you really should have high frequency transducer. It will really make a difference. So if you're out there in practice and you're just kind of starting to get into ultrasound, oftentimes when you buy the machine, the first probe is going to be your microconvex. So that 5 to 8 megahertz has like a little small round head, right? That's great it's your meat and potatoes probe, right? It's going to be your beagles and your small labs. And when you start getting smaller than that, or into cats, chihuahuas, most exotic small pocket pets types thing, you need a linear transducer. So those are kind of the two to think about when you're getting into that market.
I have to say I'm convinced on the linear transducer with like very limited experience in ultrasound, and then going into, the ultrasound course at Institute, I was kind of like, I don't think I do enough of this to really like justify multiple probes. But having seen the difference between the microconvex and the curvilinear versus the linear, yeah, it was very noticeable.
Yeah, it's kind of a vicious circle, right? Because I think I hear that from a lot of people, like, oh, I don't know if I could justify it, but you probably don't do it as much because you don't have the tools to do it in a way that makes you comfortable, and so it's kind of like trying to do surgery with equipment that's not appropriate. You're just not going to want to do it, so I think if you set yourself up for success, you'll do more, but it's a big commitment.
No, but it makes sense that if you're gonna do it, then making enough of an investment in the equipment and the education to have that comfort level. Otherwise, it's gonna sound good on paper, but that's about it.
Yeah, exactly.
One of the things that we talked about a little bit even before we turned the microphones on was cervical imaging for ultrasound, and that I don't know that is something I have really considered. So can you tell us more about that?
Yeah, absolutely. So this is something that, again, that, it's not in the forefront. When you think about ultrasound, most people think about bellies or maybe echocardiography. They're not thinking about necks. But there's a huge utility for ultrasound in the cervical region. And so by cervical, what we mean is your ventral cervical region, right? So the structures that are included in a cervical ultrasound are your mandibular and medial retropharyngeal lymph nodes. So those lymph nodes, those two lymphocenters that drain the head. So that's one utility is, if I have like an oral mass or a melanoma or some kind of mass anywhere on the head, really, you can use cervical ultrasound for staging, to look for abnormalities in those lymph nodes, and certainly for ultrasound guided fine needle aspiration of those lymph nodes to determine if there's metastasis there. And so probably an underutilized tool there. And certainly we can look at the thyroids and parathyroid glands. So in your hypercalcemic animals where you're trying to differentiate, primary versus secondary hyperparathyroidism, we can evaluate for it. Usually the primary hyperparathyroidism is caused by a nodule in a parathyroid gland. And so we can pretty easily use ultrasound to identify that, and then also to guide surgeons to say, okay, here's the nodule, it's on the right side, so that limits their invasiveness of the surgery. They can go find that nodule and remove it. So thyroid cancer obviously is a big one. We can use ultrasound to identify thyroid tumors and also to look for how invasive it is. So those tumors can be a little bit more regionally invasive, so we can look at the surrounding vasculature and get a feel for how bad it is, before you make more decisions, surgical decisions, et cetera. And so that's really the big utility. Some of the misconceptions I see are, esophageal, like, oh, is there an esophageal foreign body? I'm going to send them for ultrasound, right? So I can see the esophagus in the cervical region, but I can't trace it fully. So, if I rule out a foreign body in the cervical esophagus, that doesn't mean he doesn't have one down at the thoracic inlet or in the chest. And so, again, kind of complementary, but probably radiographs are going to be a much better test there or easier test there. So yeah, that's kind of the big thing. We can use it with limited degree to look for, nerve root inflammation and that sort of thing. But really, mostly we're talking about your ventral neck and your lymph nodes and your thyroids and your parathyroids. But super quick, easy tool that takes 10 minutes to do a good cervical scan and gives you a lot of information.
And this is another one with a linear probe because of how superficial everything is.
Yeah, we went full circle on that, yep.
Thinking about it, not really seeing loads of thyroid tumors, parathyroid tumors, and things like that. Now that you said that, I'm thinking back to a parathyroid case I did have, and certainly that's what we did, is we did a cervical ultrasound. I actually completely forgot that was an option, so I'm glad we talked about this.
Yeah, it's one of those things that when it's out, when you get those cases, you'll need to remember that, but they're certainly not everyday cases.
But it's good to remember that that's an option and all of the structures that we can see. And I love that you brought up what we can't see is that, that's not necessarily how we're going to diagnose that esophageal foreign body.
Right, absolutely.
Those can be tough if it's not like a tennis ball and it's like a tumor. My gosh.
Yeah, they're challenging.
Yes. So another area of the body that I want to ask you about imaging is the skull. It's like whenever I have a suspicion there's something going on in the skull, it gives me a pit in my stomach because I'm probably going to x-ray this dog because that's what I have, what I feel like is probably the best modality I have available to me right in that moment. But I know that I'm probably not going to get a great diagnostic result. So I would love to hear your take on imaging the skull.
Yeah. Skulls are hard.
Yes.
They're hard. They're challenging. So number one, I think skull radiographs still are valuable. And that is something, for sort of the next generation of vets that are coming out. They see so much CT in school that I didn't see, coming in. They're like, oh, well, we don't even, skull radiographs, that you don't even need them because you just do a CT or send for a CT. But like you said, that's not available for everyone. It's certainly not your first line of defense. And so don't discount the skull rad for sure. And I think it does take some practice, but even like a well-positioned DV and a lateral. So if the obliques are intimidating, start with just a really great DV and a lateral. Now, what I mean for a DV is not intraoral, just putting their head, on the plate and on the X-ray detector and shooting from dorsal to ventral and trying to make sure you get that nasal septum straight. Really, and using sort of the radiology books or whatever to make sure, because obliquity is really your worst enemy when it comes to skull rads. We can deal with a little bit of obliquity in the chest or the abdomen, but it really ruins skull rads for me. So really doing your best to get a nice straight oblique and lateral. On your lateral, you're looking for superimposition of those mandibular condyles. You're looking for the mandibles to be superimposed all the way across. The tympanic bulla is like usually a good, easy thing that you can see on skull rads, right? Making sure the left and right are on top of each other. And so that is a great starting point. And I think we can use that a fair amount to, look for trauma. Oftentimes it's for trauma or, the other one I see kind of frequently is nasal masses, right? That DV view is really kind of your best friend when you're looking for a unilateral mass. So a soft tissue opacity skulls really lend themselves for identifying soft tissue cancer because of the gas, right? So it provides inherent contrast. So I think if you kind of simplify it and think of it that way, right? Can I just get a good DV and a lateral enough to say, okay, there's something to pursue further, or I can rule out major pathology, right? So, and then once you're comfortable with that, adding on the obliques is super helpful. And the radiology books like that Thrall diagnostic imaging book, or again, reaching out to, your local resources are happy to help with that. But that's kind of a good starting point. So I don't think it's useless. Now, I do think that if you have access to a CT, far and away, that's going to be the more diagnostic test. It's very, very quick to scan ahead. We can do it under sedation. Oftentimes we'll use IV contrast, but you don't always need it, especially for things like osseous trauma. I had a dog today that I got referred radiographs, and It was a 8-month-old Chihuahua that had head trauma and concern for traumatic brain injury. And I got this kind of really oblique lateral with a note from the doctor that said, "I'm so sorry, I couldn't," we all know. And I was like, I don't blame you. I couldn't have done better. It's an 8-month-old Chihuahua, right? It's hard, but it's really not diagnostic for me. I don't know what I knew what I didn't see, but I don't know what I'm, missing from that, right? So if you have the option, especially in these trauma cases, to refer for a CT, just don't forget about that, because it really is quick and easy and super diagnostic. And then oftentimes we can use, for example, I had a head CT of a dog with a unilateral nasal mass, so probably a nasal carcinoma, and it had eaten away enough of the maxilla for me to get a needle in and get a sample. So I was able to really quickly then be able to use that CT to guide my needle in and get a sample of that nasal mass that, normally you would think requires endoscopy. So it can be certainly really, really helpful. But
yeah, for imaging the skull, even just that tip right there of I'm picturing the symmetry that we'd be able to see there. And I think that kind of opens up a whole new ability to see more things on those skull x-rays.
Oh, yeah, for sure. And obliques are great. It's just a tilt of the head, right? Take a lateral and you're just tilting the head one way or the other. But sometimes that can be intimidating for sure. So and there's a lot of structures in there. It's a lot of fine, subtle anatomy on top of each other. And that's the glory of CT, is it just takes out that superimposition, and we can see all the nasal turbinates, all of it. And so really is the cone of truth when it comes to heads, for sure.
Absolutely.
Have to meet your sister and thank her.
I will relay the message.
Okay.
Next time she's in town, I'll be like, you're gonna need to come by. And she loves imaging too. She's like, ultrasound is her jam. She's all about it.
Oh, cool. Yeah.
Along the lines of the Chihuahua that you mentioned with potential TBI, like hopefully he's okay. MRI, I'm curious because, yes, that's what I remember learning, like CT bone, MRI soft tissue. So I would think like TBI, we're talking MRI. Would that be the case? Like, where are we saying, okay, CT might not be our best option here. Let's go for MRI.
Right. So, really that kind of warrants a little bit of a discussion about the pros and cons of each, right? So, because sometimes you're just working with what you have available. MRI is significantly less available in small animal, right? They have one in our area, but, much, much more available to get a CT. So there's that component. The true benefit of MRI comes in with the soft tissues of the nervous system when it comes to veterinary imaging. So when you want to look inside of the brain parenchyma or inside of the spinal cord. So absolutely, certainly MRI would be a great test for that TBI puppy. But CT, I would certainly not discount it because it's going to show us a fair amount. So if that dog has like a hemorrhage around its brain, we'll be able to, hemorrhage has a really bright appearance on CT. It's hyper attenuating, so it'll almost make its own contrast, right? Because of the metallic components. It just really looks much brighter. So you can see acute hemorrhage really well. You can see any kind of mass effect. So anything that's pushing the brain around, you can see that. Certainly in that dog, we'd be able to see fractures, subtle fractures, much, much more subtle fractures on CT than we could see with radiographs, for example. And so it would still give us a fair amount of information about the brain and potentially enough information. But if you're really looking for the subtle detail, like you need to see the difference between the gray and white matter in the brain, then that's where MRI becomes really important. So in those cases where, you might have a more subtle intraparenchymal neoplasia that doesn't have a mass effect, it's not necessarily pushing things around, that's where MRI is going to be necessary. So I think kind of warning your owners, like, let's start with CT because it's less expensive, it's more available, it's going to give us a lot of bang for our buck, but just recognizing, like, if we have further questions beyond that, then that may be a time to consider MRI if that's an option for those people, right? So I think CT is a great starting point in those cases.
And with MRI for like parenchyma, and you're talking about with neuro type of cases, I'm assuming that's extending beyond the brain and like into the spinal cord lesions and stuff like that. We might want MRI for that.
Yeah, and again, CT also has a lot of utility there. So we all think of the down dachshund, right, or the down dog that has, you're concerned for a disc. You're not going to see much radiographically unless there's like an aggressive bone lesion or something like that. But if it's a, your classic small breed dog with a ruptured disc, oftentimes radiographs are not very fruitful. CT is helpful for those breeds that tend to mineralize their intervertebral discs. So chondrodystrophic dogs like dachshunds, you can oftentimes see that disc with CT alone and save the MRI money to go to surgery from there. Now, that's the downside is it may not be mineralized. So you may get to CT and say, well, we're still concerned about a disc, but we can't see it very well on this modality. So then you have to consider MRI. So, but for things that don't tend to mineralize their discs, like pretty much anything non-chondrodystrophic, sure, MRI is really your best bet for disc disease or spinal cord disorders and that kind of thing. So definitely a place for that there.
Yeah, and originally when I asked that question, I went, well, if it's a disc dog, then, maybe you would see it because you're looking at some of the margins of the spinal cord, not necessarily, intra-cord lesions. But with what you're explaining, that makes sense. Without that mineral component, then maybe we won't pick that up.
Yeah, no, you're absolutely right. I mean, sometimes you will be able to see that disc pushing kind of the fat around, but it's just such a small spot, and it's like a subtle difference in tissue types that it's easier to miss it on CT than it is on MRI. But absolutely, your thought process is correct. But for sure, if they're mineralized, you're going to see them. If they're not, it may be harder to feel confident.
There's just so much to imaging and radiology. I'm like, I have 8 million more questions.
Yeah. So it makes it fun though, right?
It does. It really does. The other thing that I heard you say that was interesting to me was that you could pick up on that hemorrhage and that it would have a different appearance than the brain parenchyma. Because certainly having looked at radiographs for so long, it's all soft tissue opacity, but not the case on CT.
Not specifically with acute hemorrhage. Okay. So if it's very acute, like it just happened recently in the last few hours, then it will be hyperattenuating. So it looks bright, almost like contrast would look, right? Yep. So you can see that on CT. Not the case on rads.
No, yeah. I would imagine all soft tissue on rads.
Yeah, exactly.
Well, this is just... Like I said, I have 8 million more questions, and I've learned so much just in our short talk here. So I hope I can volunteer you to say, will you please come back and talk to me about this some more, because this has been such a great talk. Thank you so much.
Yeah, my pleasure. It was fun.
Any final thoughts you want to share with everybody?
No, I mean, probably the big thing is don't be afraid to reach out. A lot of people now are using radiologists to interpret images, or they have someone that they're comfortable sending their images to. And don't forget about using those people for modality questions, right? I want to refer something for this. What's the best test? Because the worst thing for us and for the patients is to have that patient sort of go on a merry-go-round of tests that are inappropriate before we come to the right answer, right? We all want to get there quickly and do what's right for our animal. So I can speak for myself, but I feel like all of my colleagues feel this way. Don't be afraid to reach out, and we're happy to provide guidance. That's kind of what I consider one of the funnest parts of being a radiologist. So thank you so much for having me. It was fun.
Absolutely. I hope we can do it again.
Yeah.
I have to say, imaging is not something that comes naturally to me, so I learned so much from this conversation. I really want to say thank you to everyone who joined us. I hope you learned a lot too. Thank you, Dr. Porter, for joining me. It was a lot of fun having you in studio. If you enjoyed this episode, please leave us a 5-star review wherever you get your podcasts. It'll help other veterinary professionals like you find this and other great content we try to put out there. For more episodes like this, click on the Education tab on the VetFolio website. As always, we'd love to hear your input on this talk, as well as ideas for topics you'd like to hear from us in the future. Feel free to reach out to me at dvm@vetfolio.com. You can also visit my Facebook page at Dr. Cassie DVM, and you can find me on LinkedIn. And remember, if one animal is better off because of you today, it's a great day.